Hey guys, welcome back to the channel. This is Side Dental Vlogs, and today we are going to talk about how to manage a case of RCT failure. We often encounter these kind of cases in our clinic, and what happens is actually we have done a lot of effort and we gave a lot of effort to complete a particular RCT of any particular tooth, suppose lower 6, upper 6, upper anteriors, lower anteriors. So I'll make a video today and I'll make sure that few tips you should follow in order to so that the RCT is there for a long time and the crown which you put is there for a long time, patient is not having any kind of problem. So the first and foremost mistake what we do in while doing the RCT is, suppose we are doing the RCT, right, and our only concentration is finding out the canals, the very first concentration. canal मिलेगी नहीं, ठीक है, और उसी टेंशन में हम RCT करते हैं first. So forget that tension. So first of all, when you are doing a RCT, give a proper block or any anesthesia, whichever tooth is it, and then try to first remove the entire carious part of the tooth. That we often ignore. What we do is we just ditch a hole in the center, and what we find, okay, there are 3 canals. Okay, I got 3 canals. Okay, forward. Then in the process we complete the RCT and then we do the restoration, but we sometimes forget that at the sides of the restoration, at the proximal boxes, there will be some black linings or some black carious parts which we haven't removed, and which later on what does it do is it progresses to the cervical area of the tooth, and then it goes to the periodontal tissues, then it involves the furcation. Then when it is furcation involvement, then patients have they start developing a small polyp like swelling or some kind of pain, and at that time the patient, when he comes to the clinic, it's too late. So before doing the access opening, just make sure that you are removing all the carious part, or even after doing the access opening, just remove the entire carious part from the tooth first of all. Okay, जितना भी black portion है सब निकाल दो. Okay, now second thing is that mistake we are doing is we should always try to finish the maximum BMP in the first sitting itself. So what we often do sometimes is that we make a ditch hole and we just give deep pulp and send the patient. But that is we should not do. We should first start with a small file like a path file which is available. I use different kind of files. Like I'm using nowadays for the path file, I'm using Woodpecker number 10 file. It's very good. The first file which is there, W0, W1. So after that you can use any kind of file, that mix and match files, like I'm using NeoEndo also, I have HeroShaper Gold. So whatever file system you are using, it should be properly autoclaved, and it should be, all sterilization protocols should be strictly maintained. Okay, and you should not do the RCT in a you are doing it in you have to catch a bus or you have to catch a train. You have to do it very peacefully, and the most important thing is the working length of the tooth. So what we often do is first we do the RCT and we don't reach up to the working length. Okay, now we do 2 more sittings of the RCT, और उसके बाद हम क्या करते हैं कि at the end when we obturate, the GP is 2 mm short. Okay, now what we do is again, and before that appointment you have given calcium hydroxide also in the canal. ठीक है, आपको लगा बिल्कुल RCT ठीक हो जाएगा, जितना infection है कम हो जाएगा. But in the initial phase we haven't removed the infection or the periapical tissue which is present, or the periapical pulp tissue which is present in the apical one of the tooth. Okay, so at that time, now in the third sitting you did that, but you have not given enough calcium hydroxide, or you have not given enough irrigation in that area. Okay, so properly do the BMP in the first sitting itself, take some time, and in the second sitting you should give calcium hydroxide. Third sitting we should obturate the patient. Number 3 point is we should avoid doing single sitting RCTs. Only in vital tooth you should do it, not in non-vital tooth. So often some patients will be coming to you saying that I have to go to Mumbai and I have a week's time. Can you finish my 2 RCTs, 3 RCTs? You can finish, but if it's vital, if it's not infected. But if you see on the X-ray, the tooth is carious and there is a periapical lesion. So we should start the RCT on the same day itself, but you have to tell the patient that we need time. It's natural human process. It's the immunity of the body which will heal the bone, it will heal the periapical infection. It's not like that you finish the RCT in one go and later on you suffer. The patient will come back to you only because he has paid money for his treatment, and for the single sitting RCT you could have charged some 1000 or 2000 extra. But what the patient thinks कि उसने किया और खराब हो गया. He doesn't think कि okay मैंने 7 दिन ही मेरे पास time था. So it should not be like that. You should properly give time to the patient, and patient should also understand that this is an infected, it won't get over in 7 days. Let it be. Let the patient go to his native place and then come back again after 6 months or 7 months whenever he is having time, and at that time you do the full RCT properly. Fourth point is that we have to do proper irrigation, which we often miss. So after every use of every file, so what we do is we do hypo at the end. पहले saline से कर दिया, hypo end में कर दिया. लेकिन we should alternately use saline and sodium hypochlorite for irrigation. So all these things, if you take into consideration, your RCT will lead to a long-term success. For one canal, you have to use approximately 30 to 35 ml of sodium hypochlorite, any irrigating solution in the entire RCT for one canal. So you think 100 ml of solution for the entire tooth. Yes, I'm right. So this much irrigation you should do to remove every pulp tissue, every whatever is there. At the end, you should etch it with EDTA, or you can even use chlorhexidine also. Then you should obturate properly, giving time to the patient. Now next we'll move over to the prosthetic part. When you are putting a crown to the patient, ensure that when you are making the crown preparation, ensure that all the margins are properly you have given and the crown is there and it's not too short. Sometimes what happens is due to the height is reduced height of the crown, what happens is the crown gets dislodged, okay, and the patient is least bothered and he will think okay बाद में लगा लूँगा. So what happens is whenever the crown comes out, all the food items the patient is having, it's leaching inside the tooth, and immediately it should be replaced. So we have to ensure there is proper crown height is there, and if it is not there, we have to do proper CLP procedure, which is known as crown lengthening procedure. You can even do it with a cautery or a BP blade. It's very easy. I'll try to give a demo of a CLP procedure in my upcoming videos. So when you do the CLP, you get enough crown height and you give proper margins and take a proper impression and the crown. Now next part is when you're fixing the crown, it should be like you should make sure that the patient is not having any problem biting. If the crown is having some high point, choose a good lab which makes good crowns and try to make die cutting crowns. So if you make die cutting crowns, what will happen is the proper interproximal margin will be there. Maximum you will see caries, interproximal caries. Why? On like in front and on back of the tooth, because there is a lot of interproximal caries because of food lodgement. So we have to make a die cutting crown. It will take hardly some few bucks extra from the patient and from the lab also. So try to make a die cutting crown whatever you are making, PFM, zirconia. So these are the few tips which we need to do in order that so that the RCT will go for a long time and prevent failure. And if the RCT has already failed, okay, if the RCT is already failed, you have many options. Like if it is infiltration involvement is there, then you can go for extraction. And if you see if the GP is not obturated properly or the RCT has been done somewhere else, then you can always use re-RCT. You can use a GP solvent. First, what I do is I take out the crown, then I take out the cervical or the coronal filling, whatever is there, and then I put GP solvent. So there are a few files, retreatment files which are available in the market. I use NeoEndo retreatment files. It's a very good file. And so what I do is after proper isolation, I put few drops of GP solvent in that area where the GP is there. You should see the GP, that orange color points you should be able to see. And after like 5 minutes, the GP will slightly melt. So we have to insert the retreatment files in that area. The torque should be a little bit higher, like 3.5, and RPM should be like I give 200. So slowly you try to remove the GP, heat with a small that whatever instrument you're having for like obturation. Obturation pen is also good, so you can heat the gutta perca also to melt it. Slowly after proper irrigation you can remove the gutta pacha. It's not very but if you see the root canal is very well obturated and still there is infection, and it's very difficult to take out the GP from the canal basically. So if you say if the patient is having less budget, you can tell the patient for extraction also, and you can replace it with implant. And if the patient is poor and not able to afford the implant, then what you can do is you can give a bridge to the patient and tell the patient to get some discount because of the crown and RCT which already the patient has spent on you. If you have done the RCT, right? If you have done the RCT and it has failed along with the crown within a short span of time, then you should give some 1,000 or 1,500 discount and go for extraction and bridge. So these things is very common in the clinic, so you should not get worried. So if you like this video, please subscribe to this channel and please do follow on Instagram Sai_dental. Take care.